Welcome to our first video on infections of the eyes and ears. Let's begin. In this lecture, we'll discuss infectious conjunctivitis, preseptal, and orbital cellulitis. Let's start with infectious conjunctivitis. For infectious conjunctivitis, we'll talk about its definition, causes, clinical presentation, diagnosis, and management. Infectious conjunctivitis is a bacterial or viral infection of the conjunctiva. Viral conjunctivitis is the most common type of this infection. Please keep in mind that there is also an allergic conjunctivitis. However, since it is not an infection, we will not discuss allergic conjunctivitis in this lecture. Here you see an illustration of the eye. As you can see, the conjunctiva is this thin layer that covers the anterior part of the eyeball and inner sides of the eyelids. Infection or inflammation of this layer is called conjunctivitis. Let's talk about the causes of infectious conjunctivitis according to the age group. As we mentioned previously, viral infection is the most common cause of conjunctivitis in all age groups, except for neonates. Out of the viruses that can cause conjunctivitis, adenovirus is the most commonly implicated pathogen in both children and adults. In children, the most common bacterial microorganisms responsible for conjunctivitis are Streptococcus pneumonia and Haemophilus influenza. In adults, the most common bacteria causing conjunctivitis is Staphylococcus aureus. However, Pseudomonas aeruginosa is the most common cause of conjunctivitis in contact lens wearers. Let's first discuss the common clinical features for viral and bacterial conjunctivitis. Both these infections can be either unilateral or bilateral. The patient may describe their eyes as being stuck shut due to discharge sticking the eyelids together. Finally, any type of conjunctivitis is characterized by diffuse conjunctival injection or redness. Now let's discuss the clinical features which can help distinguish viral from bacterial conjunctivitis. Viral conjunctivitis is characterized by watery and scarce discharge. Additionally, there are conjunctival follicles or bumps on the physical exam. The eye discharge does not reappear immediately after wiping. In contrast, bacterial conjunctivitis is characterized by thick and purulent discharge. There are no conjunctival follicles on the physical exam. Additionally, the discharge reappears immediately after wiping. Here we see an image of viral conjunctivitis. You can appreciate these follicles or bumps on the surface of the lower lid. Please note that conjunctival follicles may also be present in allergic conjunctivitis. Here you can compare the appearances of viral and bacterial conjunctivitis. On the left image is a patient with bacterial conjunctivitis, while on the right image there's a patient with viral conjunctivitis. Please note that in both photos the conjunctiva is red or diffusely injected. The patient with viral conjunctivitis has scant watery discharge, while the patient with bacterial conjunctivitis has thick purulent discharge. Neonatal conjunctivitis is conjunctival infection within the first 28 days of life. Due to serious sequelae, the different etiologies based on the age of symptom onset and the different treatment strategies. It's worth discussing neonatal conjunctivitis separately in the form of a table. Chemical conjunctivitis occurs within the first 24 hours after birth. It is characterized by mild conjunctival injection and tearing after applying silver nitrate eye prophylaxis. Silver nitrate was once believed to prevent chlamydial conjunctivitis. In reality, it does not prevent chlamydial conjunctivitis but can cause chemical conjunctivitis. This is why silver nitrate is no longer used. Treatment for silver nitrate-induced chemical conjunctivitis is the eye lubricant. Gonococcal conjunctivitis, on the other hand, usually appears within 2 to 5 days after birth. It's the most severe and dangerous form of neonatal conjunctivitis, manifesting with severe eyelid swelling, thick purulent discharge, and corneal ulceration and edema. Treatment of gonococcal conjunctivitis involves a single intramuscular dose of cefotaxime or ceftriaxone. One can prevent gonococcal conjunctivitis by applying erythromycin eye ointment to all newborns, regardless of maternal infection status immediately after birth. Finally, chlamydial conjunctivitis occurs within 5 to 14 days after birth. It's characterized by mild eye swelling. The discharge can be either watery or mucopurulent. The treatment for chlamydial conjunctivitis is oral azithromycin. A 4-day-old girl is evaluated for bilateral purulent eye discharge for the past day. She was born at home at 38 weeks of gestation. Her mother had no prenatal care. Physical exam shows bilateral conjunctival injection and edema along with thick, purulent, and copious discharge. What is the best treatment option for this patient? This 40-year-old girl presents with bilateral conjunctival injection and edema along with thick, purulent, and copious discharge. She was born at home, suggesting that she likely did not receive the erythromycin eye ointment immediately after birth to prevent gonococcal conjunctivitis. Copious purulent discharge, along with the age of onset from 2 to 5 days, strongly suggests gonococcal conjunctivitis in this patient. The best treatment option for neonatal gonococcal conjunctivitis is a single intramuscular dose of a third-generation cephalosporin like cefotaxime or ceftriaxone. The diagnosis of conjunctivitis is mostly clinical. The slit lamp exam may show conjunctival follicles in viral conjunctivitis. Visual acuity test can identify whether conjunctivitis has affected the patient's vision. Finally, an eye culture can be performed in severe or prolonged cases, especially if bacterial conjunctivitis is suspected. Let's move on to management. Viral conjunctivitis is treated supportively with warm or cold compresses. Antihistamine eye drops may be added in severe cases. There are multiple treatment options for bacterial conjunctivitis. Azithromycin and polymyxin trimethoprim eye drops are commonly used. Erythromycin eye ointment may also be used for bacterial conjunctivitis. Finally, the preferred agent in contact lens wearers with conjunctivitis is fluoroquinolone drops. This is because fluoroquinolones cover Pseudomonas aeruginosa as well. Here is a table emphasizing the similarities and differences between bacterial and viral conjunctivitis. Pause the video and take a moment to consider this table. A 31-year-old man presents to the physician with left-sided eye discharge for the past 3 days. He had a sore throat and runny nose 2 weeks ago that resolved on its own. The physical exam shows scant serous discharge and diffuse conjunctival injection in the left eye. What's the most likely cause of this patient's current symptoms? This patient presents with scant serous discharge and diffuse conjunctival injection in the left eye. Considering that he had the prodrome of a viral upper respiratory infection with sore throat and runny nose, the most likely cause of his current symptoms is viral conjunctivitis. Please remember that in contrast to viral conjunctivitis, bacterial conjunctivitis is characterized by the thick, copious, and purulent discharge. Let's move on to preseptal and orbital cellulitis. Here's the overview slide of the topics we're going to discuss for preseptal and orbital cellulitis. Preseptal cellulitis is an infection of the deep dermis and subcutaneous fat anterior to the orbital septum. Orbital cellulitis, in contrast, is an infection of the deep dermis and subcutaneous fat posterior to the orbital septum. Let's take a look at what the orbital septum is. Here you see the orbital septum. The orbital septum is the circular layer of dense connective tissue, posterior to which there is the orbital space, while anteriorly there is the preseptal space. Infection of these anatomical spaces are called orbital and preseptal cellulitis, respectively. The most common cause of both preseptal and orbital cellulitis is Staphylococcus aureus. However, preseptal and orbital cellulitis can also be caused by Streptococcus species. Let's talk about the risk factors now. Penetrating or blunt ocular trauma can introduce bacteria into the preseptal or orbital space, causing preseptal or orbital cellulitis. Additionally, an insect bite on the face or facial infection can predispose to preseptal and orbital cellulitis. This is because the venous blood from the face is partially drained into the cavernous sinus through the orbital veins. Therefore, bacteria introduced by insect bite or previous facial infection can reach the preseptal and orbital spaces via the venous system. Finally, sinusitis can predispose to preseptal and orbital cellulitis due to contiguous spread of bacteria from the sinuses to the preseptal and orbital spaces. The common clinical features of preseptal and orbital cellulitis include eyelid swelling and erythema and conjunctival edema, also known as chemosis. Since orbital cellulitis is a deeper and more severe infection, it is accompanied by several other symptoms with which we can differentiate orbital from preseptal cellulitis. Patients with orbital cellulitis typically have pain with extraocular movements. This is because the extraocular muscles are located in the orbital space and their contraction elicits pain. At the same time, the patient with orbital cellulitis may have proptosis or outward displacement of the eyeball. This is because the orbital soft tissue is inflamed and swollen and it pushes the eyeball anteriorly. Ophthalmoplegia and diplopia result from restricted extraocular muscle movements due to swollen and inflamed orbital soft tissue. Let's talk about the diagnosis of preseptal and orbital cellulitis. Blood and eye culture is usually performed to identify whether the causative microbe has spread to the bloodstream. The main diagnostic modalities for preseptal and orbital cellulitis include CT and MRI of the orbit. These imaging studies reveal soft tissue inflammation anteriorly to the eyeball in preseptal cellulitis. In contrast, CT and MRI of the orbit show soft tissue inflammation around and posteriorly to the eyeball in orbital cellulitis. Here you see a CT image of preseptal cellulitis and an MRI image of orbital cellulitis. On the left image, you see the soft tissue inflammation anteriorly to the eyeball that is consistent with the preseptal cellulitis. On the right image, you can see the soft tissue inflammation posteriorly to the eyeball that is consistent with orbital cellulitis. Let's talk about management now. Preseptal cellulitis is usually treated with an oral cephalosporin for 7 to 10 days. In contrast, orbital cellulitis is treated with an IV cephalosporin and flucloxacillin for 10 to 14 days. If methicillin-resistant Staphylococcus aureus, MRSA, is suspected, then flucloxacillin is replaced with vancomycin. Surgery may be needed for orbital cellulitis in cases of severe proptosis and visual impairment. Here is a table summarizing the similarities and differences between preseptal and orbital cellulitis. Pause the video and take a moment to consider this table. A 25-year-old man presents to the emergency department complaining of right eye pain and swelling for the past day. His past medical history is significant for right maxillary sinusitis 2 weeks ago that was treated with oral amoxicillin. His vital signs reveal a temperature of 39 degrees Celsius, blood pressure of 125/70, heart rate of 93, and respiratory rate of 16. Physical exam shows right eyelid swelling and erythema as well as purulent eye discharge. There is no diplopia, proptosis, or pain with eye movements. Which of the following is the best next step in the management of this patient? A. Topical antibiotics. B. Oral antibiotics. C. IV antibiotics. Or D. Surgery. This patient presents with right eyelid swelling and erythema as well as purulent eye discharge. He also has a fever. Considering that there is no diplopia, proptosis, or pain with eye movements, he likely has preseptal cellulitis rather than orbital cellulitis. Preseptal cellulitis is further supported by his past medical history of the recent right maxillary sinusitis. Bacteria likely spread from the maxillary sinus to the preseptal space in a contiguous manner. The best next step in the management of preseptal cellulitis is oral antibiotics. Therefore, the correct answer is option B. Here's a table summarizing the similarities and differences between preseptal and orbital cellulitis. Pause the video and take a moment to consider this table. Let's discuss why other options are incorrect. Option A, topical antibiotics, is incorrect because both preseptal and orbital cellulitis require systemic rather than topical antibiotics. Option C, IV antibiotics, and option D, surgery, are incorrect because they are used in the management of orbital cellulitis. This patient, on the other hand, has preseptal cellulitis. And that concludes the section.